Good morning, everyone. Welcome to the second of our State of Health events for the week as we celebrate the end of a most unusual year and reflect on the achievements of our sector and of the VHA. My name's Sue Matthews, and I'm the chair of the Victorian Healthcare Association, and I'm also the CEO of the Royal Women's Hospital. To start, I would like to acknowledge the traditional owners of the many lands on which we meet today and pay my respects to elders past, present, and emerging. I'd also like to welcome my colleagues working in hospitals and community health services across Victoria and acknowledge the team from the VHA who've been working by our sides throughout this period, particularly helping us reflect on the year and prepare for the year ahead. Today, we're going to focus on delivering healthcare in the community, and in a moment, our CEO, Tom Simonson, will be hosting a conversation with Emma King, the Chief Executive of the Victorian Council of Social Service, and a strong partner of the VHA for many years. It's a topic which has been front of mind for the past 12 months, with the pandemic creating a unique opportunity for hospitals and community health services to redefine the way they deliver services and to better understand the needs of the community. We've also seen a significant increase in collaborations across and beyond our sector and a deeper engagement with the many communities that we work with in Victoria. Today, we're not only thinking about the services delivered by community healthcare organizations, but we're thinking about all of the services now and in the future, which can be delivered across the healthcare sector in our communities. For example, the Royal Women's Hospital has implemented telehealth on a scale that we never thought possible and in a time frame that we never thought possible. To help further consider these questions, we've asked two leaders from the community health sector, Tassia Michaleas from Merri Health and Glenn Pringle from IPC Health, to reflect on the insights that Emma shares with Tom. And another way we're all bringing healthcare to the community is through telehealth. And in today's session, we'll be hearing from Central Bayside Community Health and Western Health about how they have been using telehealth to continue delivering services while government restrictions required people to stay at home. As well as listening to our reflections, I encourage you to share your stories and your reflections using the hashtag State of Health on Twitter, LinkedIn, and Facebook. And please add your questions for our speakers to the chat, and we will endeavor to get answers today or at least throughout the week. We will also be unveiling a virtual time capsule for the health sector on Friday and invite you to share your photos, videos, and stories via the link on our website. If you were not able to join us yesterday, you can catch up on the first session of our website whenever you get a chance. As I mentioned, today we will be exploring health in the community with a conversation with Emma King, reflections by two of our members, and case studies on telehealth in action. Wednesday, we'll be hearing from the Ministers for Mental Health and Disability and Aging and Carers and taking a look at some of the key achievements from our sector, which you may have missed over the past 12 months. Thursday, we'll be turning our attention to 2021 and thinking about what we need to take with us. And to get us thinking differently, we'll be having a conversation with changemaker Zioni Walker. And Friday, we'll be celebrating the sector with a series of activities designed to capture the stories of 2020 and profile the hard work across Victoria, and also hearing from the team beyond the Voices of Healthcare project. It's now my great pleasure to introduce our special guest today, Emma King, the CEO of the Victorian Council of Social Service. She'll be joining our CEO, Tom Simonson, for a discussion about the complex communities and their needs in Victoria. Emma joined VCOS as Chief Executive Officer in 2013, providing a strong voice of leadership and advocacy on social justice issues for the community sector. She was previously Chief Executive Officer of the Early Learning Association Australia, and has an extensive background in the public sector and in workforce and education issues, having worked as a Victorian policy advisor, a teacher, and in a range of industrial and training roles at the Victorian Independent Education Union and the Finance Sector Union. Good morning to Tom and Emma, and I look forward to hearing this discussion.
Thank you, Sue, and welcome, Emma. It's great to have you here, and it's great to be able to talk to you about some of the things we've all been experiencing over the last 8 or 9 months. How about we start with some of your reflections of what our community has actually experienced over this, well, whatever word we want to use, this incredible period of time, the impacts on the sector that you and members of VCOS represent and support? What are your kind of headline views on what they've been through and what's been going on?
Hi, Tom and Sue, and thank you very much for having me today as well. And just before I kick off, if I can also acknowledge the traditional owners of the land and pay my respects to elders past, present and emerging. Tom, I think it's been one of this extraordinary time really, because as I've been given the message to sort of stay safe and stay home during most of the pandemic, it's really magnified a number of the inequities that already existed within our community. So we already knew, for example, that people who were living on housing estates were often not necessarily in accommodation that was fit for purpose, that, you know, it was often overcrowded, those sorts of things as well. And keeping in mind before COVID, we already had about 100,000 people on the waiting list for public housing. So more than enough people to fill the MCG when you think about it. So just touching on, that's just sort of a brief illustration, but to say before COVID even hit, we know that we had these extraordinary inequalities within our system that I think have really been magnified during COVID. What we've then seen during the time of COVID, I think, is community organisations really step up the ecosystem that exists. And it is a very strong ecosystem, actually, and when I think the community sector is at its finest, in terms of looking actually at how organisations that can look a bit like a patch, you know, it's like bringing people together to work as a bit of a sort of patchwork quilt, can kind of come together and actually deliver strongly for their community. So what we saw, I think, highlighted was community sector organisations that know that, and the community themselves, who know their community, the importance of language, the importance of culture, the importance of trust. And whenever we have an emergency, let alone a pandemic, we know that really the first places that people go to generally are their neighbourhood houses, their community health organisations, the people they already know and that they already trust. They won't necessarily go to government organisations because sometimes for a range of reasons there's a lack of trust, etc. as well. So what we saw was community sector organisations being relied on incredibly heavily and stepping up and actually saying, look, you know, we're here, we're well placed to actually serve our community, to work with our community because they are just that. And looking at, as I said, that sort of that broad ecosystem coming together. So that's a very general answer, Tom, but I think what we did see this extraordinarily, things being stood up very, very quickly. And I think when they worked best, they were deeply embedded in community and in place.
And it's interesting for me to reflect on how almost uncontroversial the increase to New Start was, despite the fact right at the beginning of this. So you talk about how fast we managed to step things up. How controversial has that been for so many years? And suddenly it's almost like it, with a bit of pressure, but it's almost like it happened overnight. And now, of course, there's pressure to roll it back. What do you think that experience kind of taught us about our advocacy for the community in the future and going forward, and the impact of that massive increase of support to people who'd struggled for a very long time without that support?
It's a really great point, Tom, because I think what it shows is that actually when it comes to poverty and disadvantage, with political will, we can turn things around very, very quickly. So we hadn't had an increase to New Start for 25 years. We have people who live in abject poverty, and we know we can change that with a political decision. And it's interesting when you talk about choices, because in this case, suddenly we had a whole lot of people who were hitting unemployment queues. We had people snaking around those Centrelink offices before the sort of dawn break. And suddenly people were saying, but I can't live on that amount of money. A whole lot of people who never anticipated they would be in that situation. And I think the images were incredibly challenging for federal government, let alone the problem of thousands, tens of thousands of people becoming unemployed at once. So suddenly they've got people who wouldn't be in that situation, and government says overnight, and to their credit, actually we're going to double the amount of New Start. We're suddenly going to reframe it and give it a new name, fine. But one of the things I think is interesting out of that, two things. One is people who lived in abject poverty suddenly didn't. And what it meant was, for the first time, they could afford food. They could afford shoes for their kids. They could afford to pay for their medicine. They could afford to pay for their bills. And they weren't living a life of luxury, but they also weren't living in abject poverty, which means it also has a huge impact, obviously, in terms of looking at health, keeping in mind the issues around housing, et cetera, which often do impact enormously on health and wellbeing. But it actually made a huge difference for a point in time. And I think it's really interesting when we look at the most recent budget, where we still don't have an ongoing amount of job seeker, what's called job seeker now, that's been locked in. But it's interesting to me that that's been continually chipped back at the same time that we've seen tax cuts for people who are doing it well. And I don't make that as a political partisan comment, but I do note that I think it's about the choices that government makes, and government can make the choice to actually change the amount of job seeker. I think there's still strong incentive in there for people to work, but actually we don't need people living in abject poverty. It is not good for people to be living in abject poverty. It is certainly not good for their health and their well-being, and then their call on community services who simply can't meet demand. And I look at the demand on community services during this time and think, well, actually, one of the interesting things is some people then didn't need the support that they ordinarily would because they had enough money to be able to pay for their own food. But we actually had a whole group of new people coming into the system who often didn't really know how to navigate it because they were hitting the system for the first time and actually never thought it would happen to them.
It's a really interesting point, because certainly across the whole spectrum of health, whether it's acute hospitals or community health services or other community services, we've seen at the same time people arrive who we've never seen before, and people we used to see quite a lot disappear. Now, unfortunately, in some cases, that's going to be because of fear. It's going to be because of other kind of barriers, but in some cases, it's actually because the thing that they really needed was to live with enough money to pay their bills and to be able to have some choices. So there are, I mean, we try not to talk too much about the silver linings of the pandemic because it seems crass, because people, you know, have suffered so much, but there are some. Do you want to, what are some of those silver linings from your perspective, beyond obviously what we've seen with New Start and Job Seeker? Some of the silver linings for our services, the way they've responded, maybe some of the things we might like to keep beyond the pandemic.
Yeah, and I think it's a really good point around the silver linings. And I think some of the things that perhaps we already knew existed, and I do think those in the world of health actually know this well, because they tend to know those that they work with, whether it's community health or hospitals. It's not generally a transactional relationship. People, people know their communities. If I look at community health, sorry, you might have to bring it back to the question, but one of the things that strikes me with community health, for example, on the public housing estates, was when community health undertook COVID tests, they didn't just go in to take a test and move on. They had a chat to people about how they were going. Is there anything else that they need? And they were trusted. So if I look at Flemington and North Melbourne, I know that CoHealth already had as their clients more than half of the people who lived on the housing estate. So they were known, they were trusted, and it's not just that sort of that transactional piece. But I know I've sort of drifted off from your question a bit there, Tom. So you might need to kind of bring me back.
We'll come back to my question in a moment, because that was one of the things that. It's kind of a combination of the two questions, but that was one of the things that I was very pleasantly surprised by. Wasn't that community health and community organizations could do that, but that they were trusted. So one of my reflections probably of pre-COVID was you and I would spend a lot of time reminding government that we can do this stuff. You don't necessarily even have to give us more money. This is what we do, although sometimes more money is good. But that was often, it felt a little bit like, maybe you would reflect the same thing, that like you're banging your head against a brick wall. Yet suddenly in the pandemic, those messages got through much more easily. And suddenly people were, I mean, there was a couple of very, I remember that day when the public housing lockdown started, and I think we were all on the phone reminding government, you really need to just let us get in there. But they did listen. To their credit, they did listen. And that was the pleasant surprise for me. What are your reflections on that kind of that ability of government to actually recognise what we can do when it really has to?
Well, I think what the pandemic showed as well, and it's an interesting thing, because you look at other emergencies. So this isn't, I think it's highlighted in the pandemic, but whether you look at Hazelwood, whether you look at the fires and floods, etc., people go to community. And I think when it's a pandemic and it's hit our whole state, it's actually that component is lifted. So I think one of the things that a number of us were calling for very quickly was saying, get community health on site fast, because actually people know them, and people are so scared in different communities. Often they don't want to go out the front door, putting aside the stay safe, stay home message. But they want to see people that they know and they trust. And one of the challenges we had was a number of those services were not able to see people face to face in the same way. So we've got these great advantages like telehealth, for example, but not everyone can access them. So we don't have that sense of who's falling through. But I think you're right, Tom. We have had so many conversations over the years, for example, around community health and this incredible service for the community, but it not necessarily being as well understood at by government. And I think that showed. And going back to your earlier point as well around the silver linings, which I think to me that is one of the, if it sounds like it is one of the silver linings in terms of, I think that ability and that community ecosystem being seen and understood for maybe the first time. And even again, looking at the housing estate situation where you look at community health and you look at local community, best place to deliver for their community, really, not the biggest surprise, but nonetheless. But some of the other silver linings I would point to, and I think we're going to touch on this a little bit later, but, and it's terrible, as you say, to talk about it as a silver lining, but so many of the inequities that already existed or the issues that already existed, I think it felt like people could walk past them. So for example, having people who are homeless, whether they be on the streets, whether they be in cars, whether they be in overcrowded dwellings, suddenly people are going, well, it's not safe. Well, it was never safe. It's just that the pandemic made it less so. So whilst it's a process that's still in motion, we saw people being moved out of those situations into different accommodation, something that we were probably told could never really happen. We've seen significant investment in our social housing system, significant investment in energy efficiency. And we've just come off the back of a state budget, the likes of which I've not seen in my lifetime. And not only because of the expenditure component, but again, it comes back to that choice and the choice that governments make about where they spend their money. And we're seeing money being significantly invested in, when I say broader kind of health and well-being, when I talk about that, I mean around housing, around energy, around education. It's all of the things that actually impact on our broader well-being for every Victorian and every Victorian community. And no matter what, we've advocated for that for years, but I think it's in the spotlight now, and we've got to find a way to hang on to that and not let it go.
And that, I think many of us leading peaks in the kind of the broader health and well-being sectors were very congratulatory of government for this budget, because as you say, I mean, I've never seen a budget. I mean, I know we can talk about where the money was invested, but in terms of our membership, there wasn't a single line that didn't go up by two-digit figures, dental 15%, community health program 11%, whatever it happened to be, family violence massively increased. So that is remarkable in itself. But then the conversation about debt comes along and how the government has funded that. And so our attention, because this was a 6-month budget rather than a 12-month budget, because it happened halfway through the year, or 6 months later than it normally would, our attention immediately moves to next May and how we get them to maintain. We know they can't maintain at those levels, but how do we get them to maintain that focus on community-based investment in those areas that there is the risk that they will turn around and say, you've had your 10 years of increased funding in 1 year, that's it. We hope that won't be the case, and maybe it's not next year's budget, it's the one after. But what are your kind of thoughts about how we really push for that not to be the case?
Oh, look, I think there's a number of reasons we can push for it, in terms of remembering too, we're moving into a so-called COVID normal. We don't quite know what that's going to look like, but the issues that we've faced before are not going away. And obviously we've got a number of issues around implementation, still some unfinished business, as I would describe it, in terms of looking at sort of short-term community sector contracts. So the very organisations that we have called on the most during the pandemic, many of whom are dealing with very, very short-term contracts with no security, and those issues still need to be addressed. If they're not, we'll see community organisations going under that actually are heavily relied upon by government. But the other thing I would really call to, I think we've got this beautiful moment in time actually to shift and to shift the parameters of the way that our state does budgeting and the way that our economy works, and that is to shift to a wellbeing economy. And if we look at, New Zealand, Scotland, Iceland, we've got that strong research and evidence from the wellbeing economies that I think we can learn from and actually shift the way that we do our budgeting. So instead, we're focusing on, for example, you might people don't live their lives in silos. So for example, you might work in the Department of Transport, but nonetheless, you should be reporting against actually wellbeing measures around, well, actually, how do you deliver wellbeing to your community? So for example, if I'm a person with a disability, I should be able to get from point A to point B just like everyone else. But we know that at the moment, generally, if you're trying to navigate our public transport system, that's probably going to be a very difficult or almost impossible thing for you, and it shouldn't be. And we can do something about it. So I think there are some things around that are almost behavioural, or if you like, or sort of some of the structural pieces around, as well as the investment that are actually going to deliver better outcomes for Victorians and Victorian communities. So for me, the shift is actually saying, let's make the most of this opportunity. Let's shift to wellbeing budgeting and a wellbeing economy. So no matter what, what's the point of, well, mind you, it's shifted in recent times, but I've always looked at it and gone, what's the point of a AAA credit rating if you've got 100,000 people that are on a public housing waiting list? People can say public housing has got lots of problems in terms of looking at, outdated buildings, etc. But the reality is we had 100,000 people lining up to get in. So we've actually got to look at how do we shift that, and I think now is our moment.
Yeah, AAA, or not anymore, but a AAA credit rating in the most livable city in the world kind of don't really chime with what we know is real life for a large proportion of our community. One of the wonderful things that we saw in the health system was long-lasting kind of brick walls between parts of the sector breaking down. So in the public housing response, we saw acute hospitals and community health services working very closely together. And it's not that they didn't work together in the past, but there certainly wasn't that closeness of partnership, that kind of basic understanding of each other's role. And, it went in both ways, hospitals to community health and community health to hospitals, about, well, what's your role here? That kind of melted away in many places. And certainly the public housing lockdown was a really good example of it, where you have the Royal Melbourne and CoHealth working together with their different skill sets, their different strengths. We've also seen those walls break down with things like, we had the terrible situation in aged care, but we've improved the relationship with aged care, partly because of that terrible situation that they experienced. What's the equivalent been in the community services sector? Have you seen those kind of subsectors coming together more, partnerships building? I hope the answer is yes, because it's awkward if it isn't, but is that what you've seen in the community services sector as well?
Very much so. And I think even giving the example around the public housing estate, and a number of our members talk a lot about the fact of having actually hospital services on the ground, community health on the ground, but also the community health organisations that were also present to say, well, actually, how do we work together? And again, moving beyond, I think we're often, organisations are often split up because of the way that funding is done and the way that, there's siloing out. And I think there's an interesting piece for us to think about there, where you look at what Department of Health and Human Services that is now splitting, and there's lots of commentary, et cetera, around that. And in a way, it's saying, well, should that make a difference, or is it fundamentally about actually how we work together and how we're funded, and also how we're not pitched against one another? Because if we look at regular times, we're often pitched up against each other for funding, etc. So all of the things that actually can call for collaboration, etc., there are, I think, often quite significant barriers that are put in the way of that. Whereas when the pandemic hit, no space for that. We actually had to just get on and deliver. And I think there's a lot of lessons to be learned from that. And also, I think a lot of relationships that were built that you hope stand the test of time, and moving beyond the relationship piece to saying, actually, what does this look like? Because fundamentally, if irrespective of where you live or what you do, you want to know that if you want a service or you want a connection to your community, you can have it. And it shouldn't matter whether if you need health, if you go into your local community health centre, if you go into your hospital, etc., your your experience should be a seamless one. And we've seen really great examples of that. So for example, looking at legal organisations that will set up in community health, for example, it says that sort of soft entry point if someone needs legal advice, and maybe even at the beginning of their appointment with their practitioner, they didn't even know that they did. It's how do we make that easy for people, and how do we bring our services together so that it's not hard for people to navigate a system that I think can often feel really overwhelming. And when I do think of it, I do think about that broader ecosystem and saying, well, actually, how do we support that ecosystem, but also how do we put in place the processes for people to make it easy. So if you go to your neighbourhood house, for example, I do feel very strongly about the importance of neighbourhood houses. They often help people do things like navigate their energy bills, or they'll help people now navigate some of the opportunities around energy efficiency. They might also say, well, look, can I introduce you to our local community health organisation if they're not there, because those partnerships already exist. So I think there's a lot to be said for actually how do we spend time, and it is a lot of time and a lot of investment in developing partnerships. It's not always an easy thing to do, but I would love to see a system that actually focused much more around looking at how do we develop those partnerships, because fundamentally for any of us, if we've got in regular times, we want to be able to connect with others, etc. But gee, if you've got a problem, you want to know that you can go, whether it's your neighbourhood house, whether it's your hospital, whether it's your community health service, etc. You just want to know that wherever you go, you can get help, and people will help you work through to, how can we join the dots for you rather than make it harder? Because often things are made so hard for people, and the pandemic, I think, lifted beyond that.
Yeah, we don't want to make it harder for people. We don't want people to feel judged. We don't want people to feel belittled. Our system has in the past been quite good at doing all of those things, unfortunately. And I think it's absolutely right. I like to think that those learnings we've had through the pandemic will not just disappear as our lives return to something resembling what we used to know. And just maybe in the last 30 seconds, if you had 30 seconds, which you do, to talk to kind of health providers and health services, what would your plea be in terms of that, not going back to kind of pre-COVID normal? What would you say about some of those wonderful things that we've actually achieved, and making sure we keep it?
A couple of things. One is around working with that broader ecosystem, but also I think that whole the life cycle of people, because I think one of the challenges we have in a budgetary sense is often money is always invested to that tertiary end. And I get it, because if you want a hospital or an ambulance, you want to know you can get in straight away. I'd love to see that spend going into prevention, early intervention, as well as a tertiary, and recognising that we often don't see the economic benefits when it comes to prevention and early intervention for some time, but thinking around how we jointly advocate in that space and jointly advocate around how we actually serve our communities. Because I think that's one of the strong sort of issues that we all have to deal with. And it's when we're dealing with really big, often big institutions, for example, hospitals, and then say community health organisations, which are smaller organisations, etc. How do we actually knit all of that together and work incredibly well, and working with our communities, and remembering first and foremost, we're delivering for every single Victorian community. How do we deliver towards that wellbeing, which is probably a bigger question and a longer time, but I really think we're up for it and can do it, and I would love to see that focus.
Absolutely, and a fantastic point to end on, because I think we're singing from the same hymn sheet. Thank you so much, Emma, for coming along this morning and participating in this conversation. Oh dear, now people are starting to ask questions. We've run out of time. I'm so sorry, but it's been fantastic. I've very much enjoyed it. I hope our audience has very much enjoyed it. As you know, we've recorded this so other people can see it throughout the day and throughout the week. It's a great working relationship and partnership between VCOS and the VHA on behalf of all of our members, but more importantly on behalf of the Victorian community. So thank you for that. It's very much appreciated.
Thank you, Tom, and thank you, Tom and Sue, for having me. I really appreciate it, and the relationship very much reciprocal, and VCOS loves the relationship we have with VHA as well. So thank you for having me.
Thank you. And now we're going to turn to a couple of our members to give their reflections on what Emma and I have just been discussing. So first I'll welcome Tassia Michaleas, who's the CEO of Merri Health, and ask you to talk about some of your key takeaways, Tassia.
Thanks, Tom, and good morning, everyone, and thank you for inviting me to be part of the discussion. I just want to really thank Emma for, I think touching on such a wide range of topics and so important. I think you covered it all really, really well and succinct. But before I do that, I want to acknowledge both the VHA and VCOS. I think you have been complete leaders throughout this time, and your support of the sector on a daily basis, not just weekly, but daily basis sometimes. We couldn't have done it without you. You've been there and you've walked beside us. It's been a challenging year. There is no doubt about it, and I think everyone knows what the challenges have been. From Merri's perspective, I think some of the key takeaways that you talked about, we experienced, and the silver linings, as you've said, that Emma talked about, are really real for us. One of the key things, in community health world is we always knew that we were connected with community. We were the trusted ones. We were the ones that the local people and local communities come to. And in the time of crisis, that trust and that partnership approach, and particularly with leaders of those local communities that we work with, is critical. We worked the front line. Our staff who work within those communities got out there, spread the messages in a culturally appropriate way, and really made those links so people could really understand what was going on, diminish their fear, and also explain to them what stay home actually meant, explain to them what testing was about, explain to them what they had to do to stay safe, because the fear took over, and there was this either a shutting down completely or a paralysing, I think is the other way to put it, of what people had to do. So it was a unique time, and it was a time where I feel community health has absolutely shone through this process in a number of ways. From my perspective, and I know from the other community, my colleagues in the community health world, so to speak, we became the fabric that really worked with community and the acute. The collaboration on the ground, and particularly across a lot of the testing sites, but then the work that some people had to do in the towers, we were the fabric that actually went in, supported that. And that's been a great opportunity, because in a time of crisis, we all came together, we collaborated. It was a case of, what are we doing now? What needs to be done? It wasn't this turf war or this competition for funding. It was like, we've got to work together. Our values shone, the partnership shone, that trust and those linkages that we already have, really, really important. A couple of the other things which I think have been opportunities and silver linings, and which will change the way we deliver services into the future, is really the telehealth component. We all had to pivot and adapt our services really quickly, and we did that really well in the face of no planning, no time to actually think about it. It was just get on and do it, and we did do it. So there will be key learnings from that we're all going to continue with and work with. So it will mean that there will be more access to communities, more services from our communities. Those barriers are broken down now. It will mean that we will be able to offer a lot more services. So they're the key takeaways, but it's been an absolute pleasure. And I think as in a time of complete crisis, the community health has worked really closely together as a group, and we have partnered really well and supported each other together with the rest of the health sector and the rest of our community partners, in particular in the new services that we're sort of running now on behalf of DHHS in terms of the high risk accommodation responses and so forth. So in a time of crisis, I think we've really shone, and we will continue to work really positively together. That's my 3 minutes, and I probably spoke too much, Tom, but I could go on all day, but I had to tighten it up. Thank you.
Your very kind comments about the VHA, but also about VCOS. You get extra credit. But thank you very much. That was really good, and thank you for giving your reflections this morning. I'll now move on to welcome Glenn Pringle, who's the General Manager of Innovation and Community Care at IPC Health, which is located in the west of Melbourne. to share what he's taken away. Glenn, over to you.
Thanks, Tom. A few key takeaways for me. I think the first one is I've often, and I think many others as well, have described COVID as an amplifier and an accelerator. For example, I think it has amplified the understanding that there are broader determinants of and factors involved in health that sit around that, you know, the social aspect, the mental health aspect, as well as the medical aspect. It has also amplified inequity, as we've heard, and that's created some significant issues that we've had to manage through COVID. And that in turn has amplified the inadequacy of many of our social protections, but that has resulted in accelerated improvements to some of those protections, which has been a really good result. And hopefully those will continue beyond the time span of this pandemic. A couple of things that have been accelerated have certainly been collaboration, and as well as that, innovation. Telehealth is a great example of how innovation has been accelerated. I think the real opportunity in the digital space, though, is to move from telehealth as a key innovation to digital health. There are so many other ways in which digital can help health become more accessible and more person-centered. Probably the key challenge and the key risk is that we need to find a way to do that without creating a so-called digital underclass, because access to technology and tech literacy is a real challenge for some people. Second takeaway for me is really this rediscovery of something that many of us kind of fundamentally knew and believed, and that's the importance of community, which in turn highlighted how important and valuable a localized response was. The idea that an understanding of and relationships with community is critical in how you actually respond to a crisis like this. And I think it also highlighted community health and other smaller community service organisations, their ability to be flexible and agile to mobilise and respond quickly in place with an understanding of the community that they were serving. The value of collaboration is another great takeaway for me. We talk about the fact that community health collaborates well already, in my opinion, but it really did enhance our ability to collaborate with the acute health services, also with city councils who, you know, we've built some great enhanced partnerships with over the last few months. Not also to forget the really important role that GPs play and the importance of their position in the system and broader community service organisations. But as well as that, community leaders, you know, in regions like ours where there is such a culturally and linguistically diverse base, it's really important to involve community leaders in the process as well. And then the final takeaway for me is probably more something that I would infer from all of that. And that my view is that, you know, we talk about a patient or a client-centered approach, but I actually think we need to move beyond that to a human-centered approach. We need to develop a deep understanding of the people we work with as whole people and all of their needs. We need to remove barriers to access to have those needs met. We need to stick with them through their journey from start to finish instead of simply set them free and cast them on to the next service provider. We need to help them navigate and have their needs met, regardless of who does that, whether it's our services or someone else's. And even more than that, I think we need to involve them in the planning and design of the services that they utilise. And I think that community health and community-based organisations can really play a huge lead role in taking a more human-centred approach, both in the health and the social services system. So they're probably my key takeaways from this morning.
Thank you so much, Glenn, and thank you, Tassia, as well, for sharing your reflections and considering what it means for community health and healthcare more broadly. It is quite amazing what can be accomplished when the funding model doesn't get in the way. I think that's one of the things I would take from this. Thanks also to Emma and Tom for that great conversation. There's lots that we can take away from this. We actually now have a special message from our partner, Russell Kennedy Lawyers.
Hi, I'm Michael Gorton and I'm a senior partner with Russell Kennedy Lawyers. We are proud sponsors of the Victorian Healthcare Association. Some may also know me as the chair of the board of Alfred Health. And so we at Russell Kennedy can very much understand the issues being faced by health services across Victoria, particularly this year. And we're proud to be a partner and sponsor of the VHA State of Health series, in which various issues and ideas are being considered. Already, Russell Kennedy has sponsored activities this year looking at the legal risks of telehealth and a governance perspective from my role at the Alfred in relation to the issues that boards and organisations have faced as a result of the crisis. And wasn't 2020 the year we had not expected? But it's raised all sorts of new ideas and new issues for us to consider. Telehealth is certainly going to be with us into the future. Care in the home has loomed large. The relationship between our health services and aged care has certainly been a dramatic issue during the course of this year. We've had to think about risk in ways that we hadn't previously contemplated. How many of us had pandemic in the top 10 risks of our hospital risk management framework? And we've had to consider the well-being of our staff during very difficult times and put that uppermost in our thoughts. So it was care for our patients, but also care for our people. And so we look forward to 2021. We look forward to the opportunities it may bring, what we want to carry over from this year, which will include different ways of dealing with patients and providing care. We look forward to that recovery. So I hope all of you look forward to 2021. Have a rest, have a break, re-energise and come back better and stronger next year.
Thank you to Russell Kennedy Lawyers for your ongoing support and for that lovely message. As you've heard, as a result of this global pandemic, telehealth has become a household name, and health services across Victoria have been busy delivering innovations which use technology to continue service delivery even when they can't meet face-to-face. I'm delighted to introduce 2 video case studies we have prepared to show you how telehealth is being used by different services. First up, we have Deborah Stuart, CEO, Central Bayside Community Health Services, who will be talking about how they transitioned many of their programs to virtual delivery. Then you'll hear from Dr. Richard Horton, Director, Department of Anaesthesia, Pain and Perioperative Medicine, and Chief Medical Informatics Officer, Western Health, to get an insight into how practitioners and consumers view the move to telehealth.
Central Bayside is a health and community-based service in the Bayside area of Melbourne, and we deliver services across a catchment of predominantly the Kingston Council, but also some other areas. I think what makes us unique is, as well as delivering a range of community health services, dental, therapy services, support, social support, we also have a medium-sized disability day program. One of the first services we had to stop operating was our disability day program, which of course was very difficult for our staff and our clients as well. So being able to connect with them on technology platforms has been fabulous. And we designed those programs very quickly. So we had a team of staff who really had never done anything like this before, but they absolutely embraced the online environment, and they developed activities, programs, information, and started very quickly to run a regular daily service. With most of our service, we were able to offer something in the digital environment. It didn't mean that that service was anything like it might have been previously. So for example, the social support groups, now they're aimed at either people that are older or perhaps vulnerable in some other domain, to provide a social connection to them. And the way those groups worked is people would come together every week. Of course, we weren't able to offer that, but we set up an approach where the staff that worked in those services each selected a group of clients and kept in contact with them right the way through. With our therapy services, some of those moved very smoothly to the digital environment. So for example, things like speech therapy, particularly in the paediatric space, and we found families were very comfortable with that environment as well. Counselling services, again, very smooth transition. And you know, I think what's been quite interesting with some of those services is that non-attendance rates actually went down. We set up a COVID response team and that was managing all our services, all our interactions and interventions with clients based on how we needed to run to keep COVID safe. That team was incredibly supportive with the clinical teams on the ground and also our disability staff, because we just streamlined all our communications that were coming through, the reasons for them, what the timelines might be. And generally the workforce adapted really quickly. We also had put in place welfare checks for some of our more vulnerable clients, and we set up what we called our red flag meetings so that we knew we would need not just a multidisciplinary approach for those clients, but potentially a multi-agency approach. Whenever we were planning anything, we had no idea of what was on the horizon. The dental team, who also had to cancel majority of their clients and were only seeing priority clients, developed 15 different videos that were focused on oral health for, some for children, some for adults, and some for older people in the community. And we would triage the clients using information gained on an initial phone call. If they weren't able to use telehealth, then they would send in photographs, and we would send photographs as well, or use the videos as a way of communicating. There are lots of learnings, and there are more learnings to come. And I think improving access to the very, very latest, most current technology is going to be critical going forward if we want to continue with these kinds of models. One of the key lessons, certainly from a disability perspective, was the value that technology can add. The use of some of those alternative service models to better meet the needs of the community would include things like being able to offer perhaps some extended hours, being able to offer a virtual group to services, particularly those services that we take out into the community. If you've got poor weather, you might have to cancel a group. Well, now you can actually say, well, let's have an online group today. Perhaps one of the silver linings of COVID, that we've been able to expand our service offerings by using technology.
The role of Chief Medical Informatics Officers is relatively new in the world, but particularly in Australia. We've only been around for a couple of years, and we're the bridge between the Chief Information Officers and the Chief Medical Officers. So that bridge between the clinical side and the technical side has been important in lots of different areas, but and it was certainly shown to be very important during the pandemic, when we needed to introduce a lot of technical fixes quite quickly. To get something up quickly, you do need good collaboration between the technical sides and the clinical sides of the business. They have to work hand in glove, particularly when there are time imperatives. We had our first COVID-19 patient present to our emergency departments in early March. Quite soon it was seen that we really couldn't have patients coming into our outpatients, so they were pretty much closed down within a week after that. From the beginning of April, where we'd had no telehealth consultations at all, by the end of September we'd had about 5,500, and of the 300 clinics that Western Health has, 62 were telehealth enabled, and that means that all the consulting rooms had been fitted out, that all the staff had been trained, and all the workflows had been established to make that happen. For the vast majority of providers and consumers, the experience is very positive, and I think against some expectations where people felt that this was a sort of a second-rate way of seeing people, I think most people actually found that it was a viable alternative and that the consultation sort of met the needs. And from the consumer or the patient side, it's clearly more convenient. It probably is only convenient for the providers if we also enable them to potentially be remote. So where we can set up that the patient is remote, the provider is also remote, then there are conveniences for the provider as well. But overall, even with all those sort of pros and cons, the feeling was very positive, and we saw our uptake increase by about 33% every month. It's not just a technical exercise. You do need the right equipment. If the technical side is not working because you've got inadequate devices or inadequate connection, then that's a real deal breaker. But there is so much else that you need to do right from the whole life cycle of the consultation, right from the time of the patient is getting booked for a consultation, so that the clerks who are doing that booking are checking the device availability of patients and their connectivity, their digital literacy, if you like, to see if this is going to be viable and potentially troubleshooting that. You certainly don't want to use it for consultations where it's a new consultation, where a diagnosis needs to be made, so physical examination is required, for example. It did require a lot of innovation and people sort of learning. I think our providers do need a lot of training and support initially. There are nuances in terms of how you would conduct a telehealth consultation versus a face-to-face. There are so many moving parts, and you need to have alignment throughout the organisation when you make any major change. The challenging side, I think I was surprised we did have trouble incorporating our interpreters into this system, and initially I thought, well, this would be ideal for getting interpreters because they could just hook into the meeting and it should be really nice and seamless. But what we found was just how complex the whole interpreter system is. The other, I think, real challenge in this is how you do prescribing and ordering of investigations. We've been doing what we've been doing for literally centuries, and I was quite surprised how quickly people adapted to it, both from the patient side and the clinician side.
Thank you, Deborah and Richard, for taking us behind the scenes of your telehealth programs and for giving us plenty to consider for the year ahead. And thank you to all of the people, from our clinicians to our IT staff to our admin staff, for working together to create a world-class telehealth program, which supported thousands of Victorians during their time of need. And thank you to everyone for joining us today. We will be posting the videos online from 11 a.m. and I encourage you to share them with your colleagues. Please join us again tomorrow at the same time with the same Zoom link for messages from the Minister for Mental Health and the Minister for Disability, Ageing and Carers. And don't forget, you can continue the conversation on Twitter, LinkedIn, and Facebook with the hashtag State of Health.